Good afternoon, everyone. My name is Gretchen McCreary, and I'm the Research Coordinator at the COPD Foundation. On behalf of the COPD Foundation, I'd like to thank you for joining us today. Before we get started, I just want to note a few housekeeping issues to keep in mind. Today's program will have 2 question and answer sessions, during which you will be given the opportunity to ask questions of our expert speaker. If you have decided to use the audio from your computer, please note that you will need to send us your questions using the Q&A feature of the webinar, which should be located on the right-hand side of your screen. If you have dialed in using a telephone, your telephone lines are automatically muted so that we avoid unnecessary background noise. But during the designated question and answer sessions, your line will be unmuted and our operator, Devin, will tell you how to pose a question. This call is being recorded, and we will let you know where you can access that recording in the coming weeks. So let's get started. We are so excited to have Dr. Chuck Daly of National Jewish Health as our expert speaker today. Dr. Daly is a professor of medicine at National Jewish Health, the University of Colorado, Denver, and Mount Sinai. He is chief of the Division of Mycobacterial and Respiratory Infections and director of the NTM Center of Excellence at National Jewish Health. Dr. Daly served as the inaugural chair of the Bronchiectasis Research Registry and currently chairs the revision of the NTM Guidelines Committee. In addition to many other accolades, Dr. Daly has been recognized as one of the best doctors in America by U.S. News & World Report and Castle Connolly, as well as receiving the World Lung Health Award given by the American Thoracic Society. So thank you again for joining us today. I will now turn it over to Dr. Daly, who will be presenting an overview of COPD, bronchiectasis, and NTM.
Thank you, Gretchen. It's a pleasure to be here today. I'd like to begin by thanking the COPD Foundation for providing me this opportunity to speak with you all today. I was asked to look at this intersection between COPD, bronchiectasis, and NTM. Obviously, we could spend days on each of these topics, so I will try to connect the dots briefly today. I'm going to do this by first starting looking at COPD and bronchiectasis. What are these conditions? What are the symptoms? How do we diagnose patients, and how are they similar or different? We'll stop, as you heard, and we'll take questions, and then I'm going to introduce the element of NTM and how NTM is important to both COPD and bronchiectasis. You'll see highlighted here some of the resources provided by or recommended by the COPD Foundation. So I begin by just some disclosures. I have had research grants from INSMED, COPD Foundation, and I have served on advisory boards for these companies all interested in bronchiectasis and NTM. So let's begin with COPD. And, the first question, of course, is what is COPD, or chronic obstructive pulmonary disease? The definition is that of a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. And that latter point is very important because that's what distinguishes it from asthma, which can be fully reversible. Now, the disease occurs when there's destruction of the walls of the alveoli, or air sacs, in our lungs. And basically, that makes the air sacs coalesce into larger units, which really do not function very efficiently. Another important element is the airway walls can become thickened and produce more mucus. All of this ultimately leads to the symptoms that the patient has, which are typically shortness of breath, coughing, wheezing, and tightness of the chest. Now, COPD is very prevalent. Globally, it's estimated there are about 250 million people with COPD, resulting in about 3 million deaths a year. The disability is spread across the world. There are some countries like India, Bangladesh, New Guinea that have tremendous disability related to COPD. The U.S., we're kind of in the middle in terms of where we are impacted by COPD. But this is a global disease and a disease that affects millions of people. In the U.S., it's estimated about 24 to 30 million people have COPD. But unfortunately, it's also estimated that probably half of them don't know it. They've never been diagnosed. And just like the prevalence varies across the globe, it also varies in the U.S. And I think if you look here at the percentage or the prevalence of COPD in people over 18 in the U.S., you can see it kind of concentrates around the Mississippi and Ohio River valleys as well as southeastern U.S. When you get into that part of the country, the percent of people with COPD is over 6% up to 12%. So that's quite a high burden of disease, both globally and in the U.S. Now, I don't think there's any secret to what causes COPD, and certainly in developed countries like the U.S., smoking is by far the most common reason someone would have COPD. But if you look globally, and particularly in developing countries, there are environmental factors, both indoor and outdoor air pollution, that are significant contributors to COPD, and more rarely things that are genetic. So if we talk about smoking, it's kind of interesting the impact smoking has here, because 8 to 9 out of 10 people with COPD have a history of smoking or are current smokers. But if you flip it around the other way, only 1 of 5 smokers develop COPD. So this really reconnects to this issue of genetics. What are the predispositions to COPD? Among environmental, the second most common cause globally are ambient air particulates. And these can be both outdoors or, as in many parts of the world, indoors or at work. And this would include things like secondhand smoke. And then the most notable genetic cause is alpha-1 antitrypsin deficiency. Now, there are many other causes that could be added, but I think these encapsulate the most important ones, particularly in the U.S. Diagnosis is usually through screening, through spirometry, in someone who presents with a history of smoking or they have the symptoms that I mentioned before. Spirometry provides us with several indices that are important to gauge airflow limitation. Spirometry provides us with a measure of the amount of air that can be expelled in 1 second, or the FEV1. It provides us with the amount of air that is blown out with a forced maneuver called the forced vital capacity. But it's actually the ratio of those two values, the FEV1 over the FVC, which gives us a finding which is characteristic of COPD or other forms of airflow limitation. And that's when that ratio is low, and that means less than 70. But it's important to recognize that that doesn't mean that person has COPD. Additional evaluation needs to be done. One of the things that's commonly done is to proceed with a CT scan to look at their lung parenchyma. And there have always been kind of 2 traditional phenotypes of COPD. One is the emphysematous and the other is the chronic bronchitic. Those terms now have kind of gone away in the sense that there's so much overlap between the two that we just call it COPD. But we do see radiographically this distinction. In the top, you'll see in this CT of the chest, there are these black circles. These are basically those coalesced alveoli that produce these black holes in the lung, and these are areas of the lung that just don't function normally anymore. And in the bottom image, you see someone who doesn't have emphysema, but they have the more chronic bronchitic phenotype. And the arrows are actually pointing at these little rings, and those rings are very thickened airway walls. So those are airways that are thickened, but they're not dilated. Because if they were dilated, then we'd be talking about this disease, bronchiectasis, the definition of which is a dilated, inflamed airway. They're usually easily collapsible, so if someone coughs trying to expel mucus, they collapse, and it makes it impossible for them to get the mucus out. And that's important in this condition because the patients often have a productive cough. Now, in the setting of emphysema and COPD, we see evidence of lung destruction, but bronchiectasis is truly an airway disease. And in this setting, we see this dilatation of the airway, which means that it cannot clean itself normally, and often we see pooling of mucus in these dilated airways and chronic infection. And this all leads to symptoms like cough, something that we also see in COPD, but in this setting, it's often productive. They may have hemoptysis or coughing of blood and shortness of breath. But also in distinction to COPD, where shortness of breath is one of the primary symptoms, shortness of breath in the setting of bronchiectasis is often a bit late in the path. So how often does this happen? Actually, we don't have as good a data on the prevalence of bronchiectasis as we do with COPD. This is a fairly recent study from the U.S. that looked at healthcare claims database. And what you see here are the estimate of about 340,000 bronchiectasis patients in the U.S. But in this paper, they said they could be off a bit, and it could be as much as 550,000, about 2/3 of which were women, and over 2/3 of which were people who were 65 and over. So I think this gives you an idea that this tends to be a disease of an older population, mostly women, but there are certainly exceptions to that. This is one of two studies the other from NIH that showed that bronchiectasis was increasing at about 8% per year in the U.S. I mean, that's a pretty phenomenal increase for any disease, and that is a very significant issue for us going forward, meaning that we should expect to see more and more cases of bronchiectasis. Now, the causes are numerous. I've kind of lumped them here into four categories of post-infection, immunodeficiency, autoimmune, and genetic. Post-infection, if you look globally, TB actually is one of the most common causes of bronchiectasis throughout the world. Right next to it is pneumonia, various viral infections like pertussis, measles, also very important causes. When we talk about immunodeficiency, generally what we're referring to in this setting is that someone has low antibody levels. Autoimmune disorders like rheumatologic diseases, and by that I mean things like rheumatoid arthritis, Sjogren's syndrome, and also inflammatory bowel disease. We see bronchiectasis in that setting. More commonly, I would say, in ulcerative colitis than what we see in Crohn's. But also very well known are the genetic causes of bronchiectasis, like cystic fibrosis, primary ciliary dyskinesia, and alpha-1 antitrypsin deficiency. Now, I'm mentioning this again because I mentioned it as a cause of COPD, but there are cases that we see that have primarily bronchiectasis as their major phenotype and not emphysema. The frequency of that, I think, still is debatable. So how do we diagnose bronchiectasis? Well, it's really based on an imaging study. It's not based on spirometry like with COPD. And this particular image shows four features that I think are important for us to look for when we're scanning for this on a CT. The first is at A, that you see the arrow. That is a dilated airway with a very thickened bronchial wall, so that would be a classic finding in bronchiectasis. If we go down to B, what you see is an airway that's running through the lung tissue, and it's not tapering. The walls are running parallel to each other. A normal lung, the airway is like a tree. Every branch, as the next branch goes out more peripherally, it tapers and gets smaller and smaller. But in the setting of bronchiectasis, it may not taper. If we go across to the other side in the left lung, we see C. And what you see there is a dilated airway sitting adjacent to an artery, so the more nodular part. This is called a signet ring because it looks like a ring, a signet ring. And this is a classic finding of bronchiectasis, and more on that in a moment. And then finally, back to the other side, looking at D, that elongated, dense structure is a mucus plug. Another very important finding in our patients for bronchiectasis, and you can imagine if you have a lot of these in your airways, you're going to cough a lot, and it's going to affect your spirometry. Now, if they were to cough that up, it might look something like this. This is actually a mucus plug that was coughed up by a patient with bronchiectasis, and literally it's a cast of their airway. And I can assure you this patient felt much better after that was coughed out. So this idea of having an airway right next to an artery, it's the normal physiology. But in a normal lung, the airway is smaller than the artery. So what you see here is something we measure when we look at a CT scan to try to determine if someone has bronchiectasis. So we measure the internal diameter of their airway, and we compare that to the accompanying artery. And normally, the bronchial diameter is smaller. It's about 0.7 that of the artery. But as that changes, as that relationship changes, and then the airway starts eventually to become bigger than the artery, that is one of the radiographic findings and actually definitions of bronchiectasis. And so here's an example. The larger arrows are pointing to the dilated airway, and the smaller ones are pointing to the accompanying artery, which is that little nodule on the signet ring. And again, envision, it should be the reverse of this. The artery should be the same size or smaller. So a very important finding. But you could also imagine that there's a gradient here. And often what you see between different radiologists, one may call bronchiectasis and one may not. And it's all about how they interpret this ratio. So this is an example of a patient with COPD who developed bronchiectasis. In 2007, there was no evidence of bronchiectasis, but if we jump over to 2015, we can see those signet rings, those dilated airways next to smaller arteries. And there was actually a systematic review looking at this overlap, and they looked at all the studies that had looked at COPD and bronchiectasis and said that 26 to 69% of patients with COPD had CT evidence of bronchiectasis. And part of that big range that you see there is related to this issue of how the radiologist did or did not call that bronchial artery ratio. So how does this happen? Well, if we think about, let's take a patient with moderate to severe COPD and they get an infection. I have bacterial infection here, could be a viral infection. That leads to inflammation of the bronchial wall, and maybe they get antibiotics and respond, or maybe their immune response wins, but ultimately something has to happen, and that is they either eradicate the bacterial infection or they do not. In the setting in which they don't, we believe this is one way they enter what's called the Cole's vicious circle. This is a vicious cycle of inflammation that we believe is part of the pathogenesis of bronchiectasis. So now that acute infection becomes a chronic infection. That leads to bronchial inflammation, the release of various molecules that are inflammatory. Those can impair mucociliary clearance. Ultimately, bronchial wall destruction ensues, and now they're more apt to get infection. So now we're into this vicious cycle. So this, we believe, is how bronchiectasis occurs in the setting of COPD. So if you compare them, there are differences between COPD and bronchiectasis. Bronchiectasis tends to occur in an older population, but not necessarily a lot older. One thing that is different in COPD, it tends to be male predominant. I hate to say this, but that predominance is changing. As more women smoke, that male predominance is closing, although we do see a female predominance in bronchiectasis. You know, I mentioned the causes are different, the imaging findings are different. Very importantly, infection issues are different. For one, in COPD, the role of infection is secondary. They get COPD from something else, but then infections become an important part of their condition. Whereas in bronchiectasis, it's very common that infection is what actually causes the bronchiectasis, and then they get repeated infections. Airway obstruction is absolute in COPD. It's one of the defining definitions. It's often present in bronchiectasis, but not always. Cough is almost always present in bronchiectasis, but not always in COPD. And even the infections they get can differ. We see more Pseudomonas aeruginosa in bronchiectasis than COPD, and we see more NTM. So the final comment regarding the first section is what happens when you get both. And I mentioned that there were some systematic reviews that looked at between 6 and 14 studies. And it turns out it's not good. If you have COPD plus bronchiectasis, you're 2 times more likely to have sputum production. You're 2 times more likely to have an exacerbation. You're 4 times more likely to harbor a pathogenic organism in higher rates of Pseudomonas. You're more likely to have severe airflow obstruction. And very importantly, you're twice as likely to die as someone who just has COPD alone. So when these two diseases, which are separate diseases, come together, obviously things get much worse. So what I would like to do now is take that break, see if we have any questions about COPD, bronchiectasis, and their interaction before moving on to NTM.
Thanks so much, Dr. Daly. We would like to now start the first questions and answer session. As a reminder, audience members have the ability to type in a question using the Q&A feature of the webinar or ask a question via phone line. In order to provide this opportunity to as many of you as possible, we ask that each caller limit themselves to 1 question. Please also recognize that we are unable to provide specific medical advice to callers. With that, I will ask Devin to please open the phone lines for questions. Devin, how can members of the audience get into queue to pose a question?
If you'd like to ask a question over the phone, simply press star, then the number 1 on your telephone keypad. If you'd like to withdraw your question, press the pound key. As a reminder, please limit yourself to 1 question.
Thanks, Devin. While audience members get queued into the phone line to ask questions, we'd like to start by taking the first question from the web-based Q&A feature. Delia, please pull the first question from online.
Sure. The first question we have is from Peggy, and Peggy would like to know if there are any dietary changes, such as the elimination of dairy, that one can make to reduce the incidence of mucus when having bronchiectasis.
Thank you, Peggy. That's a very common question. Not just dairy, but what kind of dietary changes can be made that might affect lung health. Dairy goes back a long time. I would say it's now been placed into the category of a wives' tale, meaning that the studies that have looked at this have really not been able to show that dairy affects mucus production. But having said that, that's always looking at averages. At an individual level, sometimes we see things that are not the same that we saw in studies that looked at averages. So for an individual, if they take a break from dairy and their mucus is better, then I'm all for taking a break from dairy. But I don't recommend people avoid dairy. How about the next one?
And your first question over the phone comes from the line of Nicole. Nicole, please go ahead. Your line is open.
Yes, doctor. I have one question and two. I wonder if bronchiectasis can be caused by working for a long period of time with hard liquid like paint or paint thinner or silicone.
Okay. We don't know about those specific chemicals. What we do know is it's probably more related to particulate matter for COPD, but with bronchiectasis, we really don't know if those kind of things can affect. I would say it's probably unlikely that they cause disease, but they can certainly irritate the disease in terms of making people cough more and maybe more mucus production. But I don't know of any evidence that shows they produce bronchiectasis.
There are no further questions via the phone at this time. I'll turn the call back to the presenters.
Devin, we're actually going to take another one from the online pod. Delia?
Great. The next question comes from Jane, and she would like to know if airway clearance really lessens the progression of bronchiectasis.
Thank you. That is a hugely important question. I'm not going to speak about the treatment of those two. We'll talk more about NTM, but it's no way we can't talk about bronchiectasis and address airway clearance. So airway clearance, I am convinced, is one of the most important things we can do for someone with airway disease, and including people with NTM infection. But in the setting of bronchiectasis, you just look at the CT and you see these airways that are blocked up and the spirometry is worse. We begin airway clearance. Well, several things happen. One is the cough usually improves fairly quickly. Eventually, if you look at the CT again, you will see mucus plugs have decreased, and you will usually see the spirometry improve. Having said that, it's very difficult to show you the impact airway clearance has had on bronchiectasis progression from any studies that have been done. But at an anecdotal level, it's very clear, I think, those of us who primarily focus on patients with bronchiectasis, that it helps them, at least in terms of their cough and spirometry, which could impact their breathing. But if you look for randomized controlled trials, you're not going to find them.
Thanks, Dr. Daly. We have one more from Valerie Chang. Why is bronchiectasis more common per capita in Hawaii than anywhere else in the United States?
So the prevalence of bronchiectasis and the prevalence of NTM are very high in Hawaii. If you look at who gets it, there's a couple of populations we have to focus on. One is the older population. So if you look in the U.S., some of the rates in some states are driven probably by having a large population of people over 65. That may drive up. Florida is an example. Arizona may be an example of those. In Hawaii, if you look at the other populations that are getting a bronchiectasis, it tends to be much higher in Asian and Pacific Islanders. So obviously Hawaii has a very large population from Asia. Now, why that occurs, no one has proved, but we do know there are many infections that occur in Asia, often in children, who have measles, pertussis, other viral infections. Tuberculosis, I mentioned, probably also drives up the rate that we see in Asians, which again I think is part of the reason it's so high in Hawaii.
Okay, thanks so much, Dr. Daly. Let's go ahead and start with our second session, what are NTM?
Okay. Something's wrong with this one. Oh, well. So this, just some of the figures are for some reason not showing up. That's okay. So what are NTM? So NTM, that refers for non-tuberculous mycobacteria. These are bacteria that are part of the genus Mycobacteria. And that now has over 180 species. If you actually add subspecies, it's over 190. And what you see here in this figure is if we go back to 1970, that's the number of species we had, less than 50 in 1970. Now we're up to almost 200 species if you include the subspecies by 2015. Now the most notable species of mycobacteria you know is Mycobacterium tuberculosis. It causes TB. The other is Mycobacterium leprae. That causes leprosy. But all the others are called NTM, non-tuberculous mycobacteria. So what you see in this figure, all these new species are almost all non-tuberculous mycobacteria. It's pretty remarkable. If we take let's say a segment of those, I'm showing them here. This is just some of the NTM that have caused lung disease. And I'm presenting it the way we typically divide them in the micro laboratory into what's called the slow-growing mycobacteria and the rapidly growing. The rapidly growing sounds scary, but they're really not very rapid, but they're faster growing than the slower. And by definition, basically if we see growth on a subculture in the laboratory, we call those rapid growers. If it takes longer than that, they're slow growers. But it still takes days, unlike staph and strep that take minutes. Among the slow growers, let's look at the three that I've highlighted, M. avium, M. chimera, and M. intracellularity. These are three of the most common species to cause lung disease from an NTM, and they're part of a group called MAC, Mycobacterium avium complex. This is probably the most common cause of pulmonary NTM almost everywhere that it's been looked at. In the other group, in the rapidly growing group, I've highlighted three that are now, these are actually now called subspecies. So most laboratories call them M. abscessus, but if the laboratory has appropriate sequencing and molecular technology, they can then tell you, is it true abscessus or Belledii or Macillian? So they're very similar, but they are actual subspecies, and it's very important, as I'll point out in a moment, that we distinguish those from each other. So this is a group that we call the Mycobacterium abscessus group. I want to show you, we talked about the prevalence of COPD and bronchiectasis. Let's look at the prevalence of NTM. And I'm using 4 population-based studies. These were collected and put in this table by one of my former fellows, Ted Maris. The first line shows you the results of a study looking at 4 healthcare maintenance organizations in the U.S. The study looked at the number of cases between 1994 and 2006. So under frequency, you see 2 columns. One says isolation, the other says disease. So isolation frequency just means in those 4 institutions, how many positive cultures do they have for NTM? Then if you go and look at each of the patients and try to figure out, is the NTM that was isolated harming the patient, we call that disease, and that was 5.5, and this is per 100,000. So basically almost 6 per 100,000 people in these 4 HMOs had disease from pulmonary NTM. The next one is a U.S. Medicare database, so these are people 65 and older. Importantly, these are they could not do microbiologic assessments, so they couldn't give us an isolation rate, but they could give us a disease rate. And look at that number, 47 per 100,000. That is extraordinarily high burden of disease from any disease. The next study is from Ontario, Canada, from Dr. Maris. 22 per 100,000 isolation, so a lot of positive cultures for NTM, and very similar to the previous, or the first study, about half of them were felt to have disease, but about 10 per 100,000 had disease. And then finally, a statewide study done by Kevin Winthrop and his group in Oregon showed about 13 per 100,000 isolation rate, 5.6 per 100,000. So if you add them up, the median was about 5.6. So what does that mean to you? So I mean, let's compare it to something. So let's compare it to tuberculosis. TB rate in the U.S. is 3 per 100,000. So currently in the U.S., and by the way, these were several years ago, these increases are still being documented, so it's probably even more exaggerated now. But at least the rate is probably 2 times higher than the rate of TB in pulmonary NTM. So that's a pretty striking number. The other reason I'm showing these studies is because they had trend data, and we don't often get trend data for NTM. Here you could see during the time frames that were studied, about 2 to 10% increase per year of pulmonary NTM. So just think about that. In Ontario, Canada, the rate of pulmonary NTM is increasing at 10% per year. That's just a remarkable number. And like I said before, with bronchiectasis, which is increasing at 8% per year, this is just telling us that we will be seeing more and more patients with pulmonary NTM. Now, I'm going to dive a little deeper in the U.S. So this is not a reportable disease, unfortunately. So we don't have great numbers on prevalence and incidence. But the NIH, who published this study, they estimated there were about 86,000 pulmonary NTM cases in 2010. And if those increases per year that I mentioned in the previous slide were correct, then there should have been about 181,000 patients in 2014. Now, we don't know that, but that's the estimate. But they're not distributed across the U.S. equally. And this is because these are environmental organisms, as I'll mention in a moment. And so where you live has a very big impact on the number of cases around you. So let's take a look at the states and which ones have the highest number of cases. So if you look at the annual NTM cases, and in the lower or the darker color, these are those who have over 3,000 cases a year. And it's probably not surprising. These are very populous places like California, Texas, Florida, New York, Pennsylvania. So a lot of people there, so they have a lot of cases. So it's actually better to look at the rate, so the number of cases per 100,000 like we did in the previous slide. Here we'll see it changes a little bit, but there are some states that have over 50 per 100,000. Florida, the most notable, and as we already heard before, the state that has the highest rate of bronchiectasis, not surprisingly, has the highest rate of NTM, and that's Hawaii. But one of the things, if you look across these, not only are some of them populous, but many of them have coastal borders. So water is a very important part of this formula. And so that leads me to, where did these things come from? Well, we believe most patients are infected after they've been exposed to some aerosolized droplets of water, whether that's from their showers, their water taps, hot tubs, spas, pools, just about anywhere water is, these organisms can be found. And if that water is being aerosolized in some way into the environment, and then a susceptible individual could inhale them into their lung. They've been isolated from aerosols that are produced by portable humidifiers, even from whole house humidifiers. These organisms have been found. From a study that was published several years ago from National Jewish, they were found in the dust of potting soils. And we also think that aspiration, either through gastroesophageal reflux or maybe swallowing abnormalities, could also be a way that if we were to drink the tap water that had the mycobacteria or eat it in food and then aspirate that, that would be another mechanism by which some people may become infected with NTM. So we believe that it really takes two to tango, meaning you probably have to have some susceptibility and then you have to have the exposure. This figure is showing a Venn diagram with three kind of groups that we think are at risk. So the first and probably most important are those who have underlying conditions. We've talked about COPD and bronchiectasis. With cystic fibrosis, this is a major problem in patients with cystic fibrosis, and they have, of course, bronchiectasis. Also, alpha-1 antitrypsin anomalies who have COPD and bronchiectasis. So we feel like those are two of the most important risk factors. There is a group that we know have significant exposures to water or soil. You know, and some people, they may have normal lungs. They may not have a susceptibility, but we think that if they get a large enough exposure that it may overcome their defenses and perhaps they can become infected. And in the bottom circle is probably one of the most interesting groups to us, and that's a group of people who have some innate problem or susceptibility, which we're all trying to figure out. Tend to be postmenopausal women, tend to be thin with a distinct body habits. We'll talk more about that in just a minute. But if we think about the risk of COPD, studies have shown that patients with COPD have about 2 to 10 times higher risk of getting pulmonary NTM than someone who doesn't have COPD. And even more remarkable, studies with bronchiectasis show that they have 44 to almost 190 times the risk of getting pulmonary NTM compared to someone who doesn't have bronchiectasis. And that that final number, that 188, was actually a countrywide study from Denmark that showed this. So it's pretty striking. So you need probably a susceptibility in most settings, but there is this one group, kind of we're calling them the unusual dose mechanism, who may be normal in all other regards, but just have a huge exposure. But I would say most patients fit into one of these other two circles, and they're a susceptible host. Now, the clinical presentation, cough, not surprisingly, usually chronic, may or may not be productive. Fatigue is almost universal in our patients with NTM. 80% of patients have cough and fatigue. They may have weight loss, particularly with more advanced disease. They may be coughing up blood, and they may also be short of breath. These particularly the shortness of breath tends to be later. But one of the most interesting groups is, again, this group that has this innate susceptibility to NTM. It's called Lady Windermere's syndrome. It's basically based on this play by Oscar Wilde, Lady Windermere's Fan. The idea by the people who coined this term was that patients, women, were suppressing their cough. They were fastidious. And so it's some confusion here because Lady Windermere was a young, vibrant woman in this play and had no cough and had no disease, but she has now been unfortunately saddled with a disease for eternity. And that disease we see in these tall, thin, light women. In every way we measure their phenotype, they're taller, thinner, and lighter than a control group of women that does not have NTM. They also have other morphologic features, like they have bronchiectasis, often on either side of the heart. And in this case, you'll see the front of the chest kind of dipped down. That's called pectus excavatum. So the sternum dives deep, and it narrows the width of the chest, the diameter of the chest. They may also have mitral valve prolapse, curvature of the spine. So this is a unique phenotype that has a high risk of getting NTM, but we don't yet know why. Now, if you do radiographs among all NTM patients, we can kind of divide them into two distinct phenotypes. The one is nodular bronchiectatic. This is what we see in the Lady Windermere syndrome. And here you see in the center of the CT, the heart, and on either side, these clusters of grapes. These clusters of grapes are really dilated airway. Just to point out where those are, this area here is bronchiectasis, but we can also see some here and out here. So it's not always in those two sides of the heart, the right middle lobe and lingula. The other is a very distinct phenotype, and this is called the fibrocavitary. In this setting, it looks like tuberculosis. Most of these patients go to a TB clinic until they are found not to have TB, but to have MAC. And here you see a very large cavity. In this patient, their entire upper lobe is gone. It has been destroyed by MAC in this case, and there's now a very large cavity in that area. So what's very interesting about these is that they're really distinct in the sense that the nodular bronchiectatic patients are almost always non-smokers. The fibrocavitary are almost always smokers, and therefore they have underlying COPD in most cases. So that's a very distinct phenotype, often driven by underlying COPD. Now, in terms of diagnosis, the American Thoracic Society and the Infectious Disease Society of America have come up with a criteria, it's called a disease criteria, to define whether someone who has grown a pulmonary or an NTM from a respiratory tract in fact has disease. So they need to have clinical, radiographic, and bacteriologic information. We presume they have typical symptoms, they have a typical radiograph, but ultimately this is a bacteriologic diagnosis. It's an infectious disease, so we need to grow it in the laboratory. The current guidelines say that you have to have 2 or more positive sputum cultures to be defined as having disease, as opposed to either colonized or indolent infection. Or if we can't get sputum from someone, 1 positive bronchoscopic culture would also meet the definition of disease. So if the bacteriology is important, then the microbiology lab is very important. And this process, from thinking about maybe my patient has NTM to them being diagnosed with it, is very long. Minimum of 8 weeks in most laboratories, often more than that, because you collect a specimen, it's examined under the microscope, it's cultured, eventually identified as which species, and then eventually drug susceptibility testing. This is a long process. I circled identification because that's an area that is in transition in the laboratory. We're going from these old, slow methods to molecular-based methods. Some of these methods now can give us an identification in 1 day's time. So we're in a very exciting transition in the laboratory, and it has become incredibly important that the laboratory provide this information, which, I hate to tell you, most laboratories in the United States do not tell the clinician. And an example of that is this Mycobacterium abscessus, one of the rapid growers I talked about. We now know it has 3 subspecies. Most labs cannot distinguish these 3 subspecies, and they tell the clinician and they tell the patient that they have abscesses. But you need to know which of the subspecies you have. Why is that important? The top 2, abscessus and Belledii, when treated, have a cure rate around 25%. The third one, Macilliense, cure rate is closer to 80%. So you can't tell a patient in the office what to expect if you don't have this kind of information and this level of detail, again, something that we're trying to get labs to do. So we're often left in the clinic trying to decide whom to treat. With tuberculosis, we treat everybody. It's a very easy decision. They grow TB, we treat it. But with NTM, I showed you earlier that about half of patients who grow it seem to have disease from it. So the clinician has to decide, who am I going to treat? So I look at the patient, I look at the bug that they've grown, and I look at the goals of therapy. So in terms of the patient, what I'm referring to is, are they susceptible? Do they have COPD? Do they have CF, bronchiectasis? If yes, I'm more likely to consider this a pathogen and treat. Are they symptomatic? If they're not symptomatic, I can make them symptomatic by giving them 3 or 4 antibiotics. So we're much less likely to treat an asymptomatic person than a symptomatic person. And very importantly, I think for clinicians, is if we have radiographic evidence of severe disease, particularly if we can actually see serial film showing progression. In this case, they have a right upper lobe cavitary lesion. That is lung destruction. That is treatment. That is somebody we're going to treat. Now I look at the bug, and this is an area in the previous guidelines that was not addressed. We lumped all recommendations that said you treat everyone the same duration regardless of the bug, but we know that's wrong. If you look at this scale here, it's kind of an attempt to think about them along a pathogenicity scale. So if we look at this end, these are organisms that weren't isolated in patients in the Netherlands. When they were isolated, 100% of the patients had disease. If you go to the other end, when these organisms were isolated, 0 of the patients had disease. So we spend most of our time as clinicians working in the middle, trying to figure out if someone grows avium, is this causing disease? If they grow abscesses, is this causing disease or not? So the bug is really important. We need to know which species and even in some cases which subspecies. And I think as I've alluded to, the other thing that's important are the goals of therapy. With TB, the goal is always cure. But in some of these organisms, if it's very extensive disease and the patient has a lot of comorbidities, cure is not possible. So we may be thinking about bacteriologic conversion, relief of symptoms, and prevention of progression. And this, again, very much depends on the species. So let's take a few of the more common species and look at how we treat them and what we would expect to happen. So Mycobacterium kinzaceae, I love it. It's a very treatable organism. You'll never guess where it was discovered, in Kansas, of course. 3 drugs. These are TB drugs. INH, ethambutol, rifampin, been around for decades. We treat all patients for over 12 months past the time of culture conversion. So I'd say probably on average for most patients, we're talking 12 to 18 months. But look at the expected cure. Almost everybody. So if a patient comes in with, and I think they have kinzaceae, I know when we're embarking on therapy, I'm going to cure that patient. What if they come in with MAC, one of the Mycobacteria avium complex species? Here, 2 of the same drugs that we use for TB, ethambutol and one of the rifamycins. But the most important drug is now the macrolide. And typically, that's azithromycin or clarithromycin. Here, the expected cure based on published data varies a lot, 56 to 85%. And that variation is based on the extent of disease. So people who have the cavitary form of disease tend to be lower down in the 50s. People with the nodular bronchiectatic disease, less lung destruction, tend to be up in the 80s. Now let's look at what happens if you have a Mycobacterium abscessus. This is the one I mentioned that had the subspecies. And it turns out your cure rate varies from 25 to 80% depending on which of those subspecies. And we treat it with oral regimens, inhaled drugs, but unfortunately, we usually need 2 to 3 intravenous drugs, often for 2 or more months, just to get control, not even to necessarily get cure, but to get control. So you can see here 3 of the more common pulmonary NTMs, how variable the outcomes are and how important it is that we know which species our patients have. Now, does it matter if you have COPD or bronchiectasis? Turns out there are some variations here in what we might expect between our patients with COPD and NTM and those with bronchiectasis and NTM. Even the organisms vary a little bit. Patients both with COPD and bronchiectasis, MAC is still the most common cause in almost all areas that have been studied. But Mycobacterium xenopi, Mycobacterium malmoense, these are some many of you have probably never heard of, but they usually occur only in the setting of COPD. In bronchiectasis, on the other hand, we see a lot of abscesses in our bronchiectasis patients. With COPD, we see that fibrocavitary form, whereas in bronchiectasis, it's usually the nodular form. It may or may not have cavitation. Treatment, we typically, because of the cavitary nature and more extensive nature in COPD, we often have to use intravenous amikacin or streptomycin. We may have to use those in the setting of bronchiectasis if they have cavitation, but otherwise we usually don't. And as I alluded to before, if you have cavitary disease, something we see in the setting of COPD, we see a worse treatment outcome than we typically see in those who have bronchiectasis, particularly bronchiectasis without cavitation. So let me summarize by saying that COPD is a chronic lung disease, and it is characterized by lung destruction, and that's why they're short of breath. Bronchiectasis, on the other hand, is really more of an airway disease with dilated and inflamed airways, and it is more associated with a cough, often a productive cough, but not always. As I showed you, when you put these two together, though, the phenotype is worse. Mortality is higher, symptoms are worse, exacerbations more common. Both of them are highly susceptible to getting NTM, but particularly in bronchiectasis, where the rate is the highest rate or the highest risk of anything that we know for getting NTM. Treatment is really, we start the same except for the issue of cavitation, in which we will add the amikacin, the streptomycin. So the outcomes tend to be a bit worse in our patients with COPD because they have cavitary disease. And it's also a group that we will sometimes move to do surgical resection if it's focal, and we can take that out. So the intersection among these, I hope I've kind of given you some idea how COPD and bronchiectasis are the same and how they differ, how they're both highly susceptible to NTM, and how we go about managing our patients with NTM. So with that, I'm going to stop and hope we have time for some more questions.
Thanks so much, Dr. Daly. We would now like to open it up for questions again. So as a reminder, we ask that each caller limit themselves to one question. Devin, will you please announce the instructions again for asking a question via the phone?
And again, if you'd like to ask a question over the phone, please press star, then the number 1 on your telephone keypad. If you'd like to withdraw your question, press the pound key. As a reminder, please limit yourself to one question.
Thanks, Devin. Meanwhile, let's start by taking the first question from the web-based Q&A. Delia, would you like to help us with that?
Sure. Barbara from online would like to know, what can I do to prevent NTM reinfections?
Barbara, if I had that answer, I would be a wealthy man. We don't know. I mean, honestly, we don't know. I can tell you some things that make sense, and that's what we tell you. So if whether I tell you or someone else tells you how you can prevent it, it's because it makes sense, but not because we know it works. So if we are correct that aerosolized water and soils are where we typically get infected, then we just need to think about how to avoid those, avoiding hot tubs, spas. Some people don't take showers. I can't tell you whether that's going to reduce the risk, but it makes sense that it might because there's so much aerosol exposure. Shortening the time you take showers. I think ventilating the room is probably as important as whether you take a shower or not. Just having good ventilation, fan on, windows open, to decrease the concentration of anything that's generated by the aerosol. And if we're correct that reflux and swallowing abnormalities could also be a way that we would aspirate the organisms, then being diagnosed with that, because about 75% of the people who've been shown to have GERD and have NTM have no symptoms. So if we don't look for it, we're going to miss it in many, many patients. But once we find evidence of GERD and swallowing abnormalities, doing something to prevent that. So from that approach, thinking about how to prevent aerosolization, there are some data that showing that if you increase water temperature, the concentration of the organism in your water goes down, so it makes sense to do that. But whether it actually long-term protects you, we don't know. Because the final thing I'll say is because we really don't know where people are getting infected. Yeah, we have anecdotes of people who got infected in their shower and their hot tubs at work and so forth. But for the vast majority of people, we actually don't know where they got infected. So I think it's a very important research question. We are strongly encouraging funding agencies to try to fund that kind of research so we can then answer your question, the best way for you to prevent yourself from getting reinfected.
And your first
Thanks,
question
Dr.
over
Daly.
the phone comes from the line of Kathy Morrow. Please go ahead, Kathy. Your line is open.
Yes, I'd like to know, is there a way to help prevent coughing up blood when you have bronchiectasis? The only thing I've been able to do is cut way back on the use of the acapella.
Mm-hmm. Yeah, Kathy. So, when people cough up blood, there are multiple reasons. Often there may be a low-grade bacterial infection, kind of a bronchitis. Sometimes just treating that will take care of that for sometimes forever or a long time. Sometimes it's something more ominous, meaning that if there's another infection that may be causing some lung destruction or that cavitation that we see. So usually we'd want to at least try to find out where the bleeding has come from, which can be quite difficult, but at least try. In terms of prevention, I think what you're doing is critical. So we know that if we start shaking up someone with vest or acapellas, aerobicas, and making people cough, sometimes that will burst a little vessel in the airway and they will bleed. So what you're doing is appropriate. You should kind of take a break from that a few days, then kind of add it back slowly, and most people can go on and not bleed again or not for a while. If that's not working and you're bleeding more and more, I think that's where you really need to be investigated, probably bronchoscopy to look to see if there's a clear area that could either be resected or cauterized to try to prevent it. But yeah, beyond that is treating underlying infection. If you're doing airway clearance, back off from that a little bit, and usually the blood will at least improve.
And your next question over the phone comes from the line of Sal Accardo. Please go ahead, Sal. Your line is open.
Okay, thank you. I've had NTM and Pseudomonas for over 15 years, and so far nothing seems to work, whether it's the oral antibiotics or the IVs. And through my pulmonologist in New York City, Dr. Adrizo, I'll be entering into a new clinical study by this New Jersey company whereby they use white blood cells to treat this. If I'm fortunate to get one of these strengths, the medication, I'm wondering what your thoughts are about this new medication.
Yes, so, well, I'm not sure which study you're referring to specifically. We're very excited that actually studies are happening now, in our patients.
This is the one in This is one by the company in New Jersey. Insmed?
Insmed, yeah. So Insmed, I'm part of that trial, so disclosure. They're looking at a neutrophil elastase inhibitor to see if they can, by giving that, if they can decrease the inflammation in patients who have bronchiectasis. So yeah, we're part of that. We're very excited that there's an actual product to study specifically for bronchiectasis. In terms of why you're not responding, you're being seen by a world expert, and so I don't think I would have much to add to that, but to your care. But your story is not uncommon, that we can't get rid of the infection. And in that setting, we do go through a very methodical step. Can we strengthen the regimen in some way? Is there a surgical option here? Is there a part of the airway that is most affected or the lung that we can remove? And then in your case, are there studies that you can be involved in, something new that might help? So thank you for taking that step to be involved.
What about the immunotherapy? Is there anything on that forefront that might also be helpful?
Yeah, so there are 2 studies that are ongoing. Most of these have been in CF patients, one of which is using inhaled nitric oxide. It's not so much immunotherapy, but it's trying to kill the organism through a non-antimicrobial way, because the nitric oxide is directly toxic to the organism. So those are ongoing. And there is it's called GM-CSF. It's a medicine that stimulates the macrophages. So that is also ongoing, and that is more of an immune stimulant. There have been over the years, inhaled as well as subcutaneous interferon gamma has been used. There's some interest in that, but not as much as there used to be because of some trials that were not very positive. So yeah, there are things happening that are trying to look at alternative ways to kill the organism or boost the immune system. And there's some more coming, but we're pretty excited that there's some interest in industry now to develop these.
Perfect. Thank you, Dr. Daly. We have one more question from online that we'd like to take. This is from Thomas, and he wants to know, is it okay to swallow sputum, or is it best to spit it out when possible?
Thomas, it's a good question. It's a very common question. But I have a very, I hope, clear answer for you. It's totally okay to swallow it. When you swallow, whatever you swallow, it's going to go to your stomach, which is a very hostile environment for things. Yes, mycobacteria can survive there, bacteria, some fungi, but not a lot. So swallowing it, it's just going to go right through your intestinal tract and be out. So there is no problem. The only time that I don't want you to swallow it is when we need a sputum specimen. then you have to get it out. And some people really have a difficult time producing sputum. But if you're in a situation where you cannot spit it out, it's fine to swallow it.
Great. Thank you, Dr. Daly. First of all, thank you all for taking the time to be here, and to Dr. Daly for the wonderful and informative presentation. I hope that everyone has found this webinar helpful. If you still have unanswered questions, I would encourage you to sign on to Bronch and NTM 360 Social and post your questions in the questions and answer section. Bronch and NTM 360 Social is our free online community and serves as an excellent resource for patients and caregivers. It can be accessed by visiting www.bronchandntm360social.org. Let me repeat that, www.BRONCHANTM360social.org. Within the next week, everyone can expect to receive a follow-up email from us at the COPD Foundation. The follow-up email will include information about helpful resources as well as a link to a survey which will allow you to provide us with feedback on this event. Thanks again, everyone, for joining us today.
Thanks, everyone.
This concludes today's web conference. You may now disconnect.